UCI School of Medicine and the VA Long Beach Medical Center, and today we will be discussing an approach to identifying acid-base disorders from arterial blood gases. There are many ways of doing this, but I find that systematically going through in your method of choice will ensure that you won't miss anything, especially in more complicated settings. So without further ado, let's jump right into things. Let's first review what information we can glean off an arterial blood gas. First, we can assess the oxygenation of the patient with both the PaO2 and the oxygen saturation. Second, ventilation can be assessed with the PaCO2, which essentially tells us how well the lungs are able to excrete excess acid from our body. Third, the bicarbonate levels in the blood help us ascertain how well our kidneys are able to get rid of excess acid from our body, and also how well the kidneys are able to retain bicarbonate. The pH of the serum then serves to represent the balance between acid generation, acid excretion, and bicarbonate retention excretion between the lungs and the kidneys. So let's go through the steps to identifying acid-base disorders. The first is to identify whether you have an acidosis process or an alkalosis process. The second is to identify whether it's a primary metabolic or respiratory issue. The third is to calculate the expected metabolic or respiratory compensation. The fourth is calculating the anion gap, which is the serum sodium minus the serum chloride minus the serum bicarbonate. And the last step for high anion gap metabolic acidosis is to calculate the delta gap. And this is the change in anion gap divided by the change in bicarbonate. I'll go over these in the next couple of slides more in depth. So if you have a delta gap that is less than 0.8, you likely have a concomitant non-anion gap metabolic acidosis, along with your high anion gap metabolic acidosis. And if your delta gap is greater than 1.8, then you have a concomitant respiratory acidosis or metabolic alkalosis in addition to your high anion gap metabolic acidosis. So the first thing is to identify whether it's a primary metabolic or respiratory acidosis after you've checked the pH and determined whether you have an acidosis process or an alkalosis process. So the first thing to do is look at the direction of the PCO2 and the bicarbonate levels. So if you have an acidosis situation, which is a pH of less than 7.4, if your PCO2 is greater than 40, then you likely have a primary respiratory acidosis. There's something driving the carbon dioxide level up higher, likely a respiratory process. Conversely, if you have a bicarbonate level that's less than 24, then it's usually a primary metabolic acidosis, where your kidney is not able to excrete enough acid, resulting in a bicarbonate that's lower. If you have an alkalosis process where your pH is greater than 7.4 and your PCO2 is less than 40, then you usually have a primary respiratory alkalosis. And conversely, if your bicarbonate is high, then there's something in the kidney that's retaining your bicarbonate level, which results in usually a primary metabolic alkalosis. And if it doesn't fit in the pictures, then you probably have some multiple processes. And if you go through step by step looking at each one, you'll be able to identify those other processes going on. So let's look at the formulas that are used to calculate the expected metabolic or respiratory compensation. It will be helpful if you actually take a screenshot of this, or you can write these formulas on the side. So feel free to pause the video now if you need to write these formulas on the side. So if you have a primary metabolic acidosis, this is the formula that you should use to calculate the expected PCO2 level. It's 1.5 times the bicarbonate plus 8, and then there's a fudge factor of plus or minus 2. This formula is also known as the Winter's formula. You might have heard that in your other conversations. The second formula to note is for metabolic alkalosis. So if you have your bicarbonate that is high, then your expected PCO2 is 0.7 times the bicarbonate plus 20 plus or minus 5 is your fudge factor there. Now let's go to the primary respiratory processes. So if you have a primary respiratory acidosis, the bicarbonate level, the expected bicarbonate level in the acute setting is you have your PCO2, every increase in 10 in your PCO2, you'll expect your bicarb to increase by 1 point. Okay. Now, if you have a chronic process, then the bicarbonate is expected to increase by 4 for every 10 in your PCO2 level. Okay. Now for a respiratory alkalosis, you're going the opposite direction. So the bicarbonate level is expected to go down by 2 for every 10 decrease in your PCO2. They should move in the same direction. Okay. And conversely, if you have a chronic respiratory alkalosis, then the bicarbonate should drop by 5 for every 10 decrease in your PCO2. The next step is to calculate the delta gap, which is the change in anion gap divided by the change in bicarbonate levels. In a pure high anion gap metabolic acidosis, we expect that the change in bicarbonate should essentially account for the change in the anion gap. Hence, the delta value gap should be around 1. If the ratio is less than 1, the bicarbonate level is lower than expected for the anion gap, which signifies there is something else driving the bicarb lower, and we likely have a concomitant non-anion gap metabolic acidosis. Conversely, if the ratio is elevated greater than 1.8, then the bicarbonate level is higher than expected for the anion gap, and we have something driving the bicarbonate higher than expected, which can signify either a metabolic alkalosis or a respiratory acidosis. And remember that only one respiratory process is allowed, so you can only increase or decrease your respiratory rate. But you can have multiple metabolic processes at the same time. And there are instances where you can have a high anion gap metabolic acidosis and a metabolic alkalosis as well, as we'll see in the following cases. Let's briefly talk about the bicarbonate fallacy. Many times we will look at the chemistry panel and declare that a low bicarbonate level, for example here with a bicarbonate of 19, is due to a metabolic acidosis. The majority of the time this is true, but as you can see here in this example, in this ABG with a pH of 7.7, which represents an alkalosis, the PCO2 is low, which means you have a primary respiratory problem, and the bicarbonate is 19, which is the opposite direction of what you expect for the pH. Okay? So if you actually calculate the compensation for this, we expect that the drop in bicarbonate from 40 to 24 will drop the bicarbonate level by about 3 to 4 points, going from about 24 to about 20 to 19. Okay. So remember that this is actually an expected bicarbonate compensation for the respiratory alkalosis problem here. Okay. So keep in mind that a low bicarbonate is not always a metabolic acidosis, and you want to rule out a respiratory alkalosis. The majority of the time it is true that it is a metabolic alkalosis. But in the setting where you have a clinical picture that's not matching your ABG, you always want to make sure that you get the full ABG in order to rule out any other respiratory process that may be contributing. Now, conversely, a high bicarbonate is not always a metabolic alkalosis as well. And in this case, you want to rule out a respiratory acidosis causing the high bicarbonate levels. The remainder of the slides will be practice questions, which will hopefully solidify the stepwise approach I have provided to interpreting ABGs. You can pause the video after the case presentation to see if you can get the right diagnosis, and then resume when you're ready to check your answers. There will be 6 different cases of increasing complexity, but I am confident that if you go through them systematically, you'll get each of the one correct. Let's go. So here's the first case. We have a 66-year-old male, post-op cardiac arrest. He is coming in with a pH of 7.27, a PCO2 of 55, bicarbonate of 24, and then the chemistry panel is listed here with a sodium of 138, potassium of 4.7, chloride of 103, and a creatinine of 0.7. So go through each step. Step 1, acidosis versus alkalosis. Step 2, identifying whether this is a metabolic or respiratory process. Step 3 is calculating the compensation for whatever is the primary respiratory or metabolic process going on. Step 4 is calculating the anion gap. And step 5 is calculating the delta gap if you have a high anion gap metabolic acidosis. So feel free to pause the video here before moving on to see if you can get the right diagnosis. And then when you're ready, click the play button to continue. So let's go through this one by one. So here we can identify that because the pH is less than 7.4, we have an acidosis issue. Now this is a respiratory issue because the PCO2 is greater than 40 and it's moving in that direction. Okay. Step 3 is to calculate our compensation, and this is our formula which we'll use. So we likely have an acute respiratory acidosis. Post-op cardiac arrest is not a chronic condition, hopefully. Bicarbonate should increase by about 1 for every 10 increase in your PCO2. So the expected bicarbonate increase is 1.5, which is 40 to 15 is 40 to 55 is 15. So 10 times 1.5 is 1.5. So you'll get 1.5 plus 24 is 25.5. And here we can see that the bicarbonate is reasonably compensated. 24 is close enough to 25.5. Okay. So for right now, we have an acute respiratory acidosis. Now let's calculate your anion gap, which is 138, your serum sodium, minus the serum chloride, minus the serum bicarbonate. 138 minus 103 minus 24 is 11, which is normal. So an anion gap of about 12 is normal, give or take a couple of points. And the delta gap is not necessary because we have a normal anion gap. So here the diagnosis is an acute respiratory acidosis, and that's all we have. Let's go to our second case here. We have a 19-year-old female with insulin-dependent diabetes mellitus. She's admitted for polyuria and thirst. This is her ABG and her chemistry panel. We have a pH of 7.26, a PCO2 of 16, bicarb of 7, and the chemistry panel showing a sodium of 136, potassium of 4.8, chloride of 101, and a creatinine of 0.9. So again, pause the video here, see if you can go through the steps before moving on. And when you're ready, click on play, and then you'll get to see the answer. So let's go through this one by one again. So here, in our first step, we've identified that the pH is 7.26, which is less than 7.4, so we have an acidosis problem. Here we have the PCO2 going down, which is the opposite direction of what we expect if it's a respiratory process, but our bicarbonate is going in the right direction for an acidosis. So we can see here that we likely have a metabolic acidosis, okay, because the bicarbonate is low. Now let's calculate the compensation. We use the Winter's formula here with the expected PCO2 being 1.5 times the bicarbonate plus 8 plus or minus 2. So the expected PCO2 here is about 18.5 plus or minus 2. And you can see here our PCO2 value on the ABG is 16. So it's reasonably compensated at 16 when we expected it to be around 18.5. Now let's calculate the anion gap. 136 minus 101 minus 7 is 28, which is elevated. And because we have a high anion gap metabolic acidosis, we need to calculate the delta gap. And our delta gap, remember, is our change in our anion gap, which is 28 minus 12, divided by our change in bicarb, which is 24 minus 7. And we get to 16 divided by 17, which is about 1. So here we've identified that we only have a high anion gap metabolic acidosis, which is consistent with steps 1 to 4. And our diagnosis is a high anion gap metabolic acidosis. Okay. And if you look back at the stem, we can see that this diabetic patient for polyuria and thirst with an acidosis, she's likely coming in with diabetic ketoacidosis. Let's go to the next question here. So in case 3, we have an 83-year-old female coming from a skilled nursing facility admitted for weakness and areflexia. We have a pH of 7.58, a PCO2 of 49, bicarb of 45, sodium of 145, potassium of 1.9, chloride of 88, and a creatinine of 0.9. So again, pause the video here to go through the 5 steps, see if you can get that, and then click play when you're ready to move on. So the first step we have here is identifying that the pH is greater than 7.4, so we have an alkalosis process going on. Now let's take a look if we have a metabolic or respiratory process. So the PCO2 is higher than 40, which could mean that we have a respiratory acidosis going on, so that's not going in the right direction. But our bicarbonate level is 45, which is greater than 24, which means that our bicarb is going in the correct direction for an alkalosis problem. And hence we have a metabolic alkalosis. Okay. Then the next step is to calculate the compensation. So the PCO2 here is 0.7 times the bicarbonate plus 20 plus or minus 5. And if you plug in the numbers here, our expected PCO2 is 51.5 plus or minus 5. And if you compare to the 49 that we have on the ABG, that's roughly about correct. And so we have a primary metabolic alkalosis, which is compensated. Now let's calculate the anion gap. So 145 minus 88 minus 45 is 12. That's normal. And hence we don't need to calculate a delta gap. And our final diagnosis here is a metabolic alkalosis. Okay. So let's go to the next step. We have a 60-year-old female admitted with pneumonia on a thiazide diuretic. pH is 7.64, PCO2 is 32, bicarb is 33, sodium is 145, potassium 2.1, chloride 100, and a creatinine of 1.2. So again, pause the video, and when you're ready to move on to the next step, just press play, and you'll get to see the answer. So let's go again, one by one in this case. So here we have a pH of 7.64, which signifies that this is an alkalosis process. Now let's see if there's a metabolic or respiratory problem. So our PCO2 is going in the correct direction, which is less than 40 for an alkalosis. So ideally, we can have a primary respiratory process, but if we check the bicarbonate level is also going in the correct direction for an alkalosis. Okay, so potentially we have two processes going on here, both a metabolic alkalosis as well as a respiratory alkalosis. Now, let's see which one is priority, and you can choose either one to calculate your compensation, whether it's a respiratory or a metabolic process. I like to take the metabolic process first. Okay, so if we calculate our expected PCO2, it's 0.7 times bicarbonate plus 20 plus or minus 5, and the expected PCO2 in this case is actually 43. Okay, and as you can see on the ABG, the PCO2 of 32 was actually less than the expected PCO2 of 43, which means that you have something driving the PCO2 lower, which accounts for your respiratory alkalosis. So you have a concomitant respiratory alkalosis as well as your metabolic alkalosis, okay, which we knew in the first place, but the compensation calculations actually help to confirm that. Then the next step is to calculate your anion gap. 145 minus 100 minus 33 is 12, which is normal, and hence we don't need to go to the next step of delta gap. So in this case, we actually have two primary processes going on. We have a metabolic alkalosis as well as a respiratory alkalosis here. Okay. Let's go to the next question. So this is the next case. We have a 23-year-old female with vomiting, polyuria, and thirst, pH of 6.99, PCO2 of 13, bicarb of 3, sodium of 134, potassium of 7.7, chloride of 104, and a creatinine of 2.8. Okay. So go ahead and pause the video here, go through your steps, and when you're ready, press play, and you'll get to see the answer. So let's go through this one by one. Here we have a pH of 6.99, which is pretty severe, and hence we have an acidosis problem. Now, if we look at the PCO2 and the bicarb, the PCO2 is going in the wrong direction, but the bicarb is going in the correct direction, downwards, for a pH of 6.99, so we have a primary metabolic problem. Now, if we calculate the compensation, the PCO2 is expected to be 1.5 times the bicarb plus 8 plus or minus 2, with the expected PCO2 to be about 12.5. So in fact, despite the PCO2 being very, very low, the bicarbonate is very low as well. So this is actually reasonably compensated for this patient. Okay. The lungs are doing the appropriate job to try to blow off as much CO2 as possible to try to bring the pH up. Now let's calculate the anion gap. 134 minus 104 minus 3 is 27. We have a high anion gap metabolic acidosis. So let's calculate our delta gap. Okay. We have 27 minus 12, the change in the anion gap, divided by the change in the bicarbonate, which is 24 minus 3. And we get 15 over 21, which is about 0.7. So we actually have a concomitant non-anion gap metabolic acidosis. There's something driving the bicarb lower than it should be compared to the anion gap. Okay. So in this case, our diagnosis is actually a high anion gap metabolic acidosis, as well as a non-anion gap metabolic acidosis. Okay. So pause here. This is a little bit more complicated before we move on if you have any questions. And if you're ready, we can move on to the last case. So this is the last case. We have a 55-year-old female with diabetes, found semi-comatose. She has a history of being on digoxin and hydrochlorothiazide. Her pH is 7.41, PCO2 of 32, bicarb of 19, glucose of 67, and an anion gap that's already calculated for you at 34. Okay. So go through each step individually, and when you're ready, click on play, and we can go to the answer. So let's go through this one by one, because this is a little bit more complicated. So here we can see the pH is 7.41, which is essentially almost normal. But if we look at the PCO2, we see the PCO2 is not normal. So we expect potentially that there is some sort of respiratory alkalosis going on, maybe. But the bicarbonate is also low, so maybe we think that there is a metabolic acidosis going on as well. Okay. So we could have both a respiratory alkalosis and a metabolic acidosis, which makes sense because the pH is actually normal in this case. So there's two things driving the pH going up and one pH going down, and that actually balances out for you to have a normal pH. But based upon the PCO2 and bicarb, we know that this is absolutely not normal. So let's go through one by one to see if we can tease out if there's anything else going on. So again, we have a metabolic versus a respiratory problem. You can choose either one. I like to go with the metabolic process. So if we calculate the metabolic process, the compensation for that, we have our expected PCO2 is 1.5 times the bicarbonate plus 8 plus or minus 2 from Winner's formula. And the expected PCO2 in this case is 36.5. So this actually confirms that we have the respiratory alkalosis because our PCO2 is lower than the expected PCO2. Okay. So here we've confirmed that we have a metabolic acidosis as well as a respiratory alkalosis problem. Now we know our anion gap is 34, that's given to us already, so we have a high anion gap metabolic acidosis. And then we calculate our delta gap. Our delta gap is 34 minus 12, the change in the anion gap divided by the change in bicarbonate, which is 24 minus 19. We get 12 over 5, which is definitely greater than 2. So we have a concomitant metabolic alkalosis or a respiratory acidosis problem on top of the high anion gap metabolic acidosis. Okay? But remember, we can only have one respiratory issue at a time. So here we have a high anion gap metabolic acidosis. We've confirmed that we have a respiratory alkalosis already, and hence we cannot have a respiratory acidosis at the same time we have a respiratory alkalosis. So the way we put this together is from the delta gap, we have a high anion gap metabolic acidosis, we have a concomitant metabolic alkalosis, and from step 3, we also know we have a respiratory alkalosis. So there's actually a triple acid-base disorder, a high anion gap metabolic acidosis, a respiratory alkalosis, as well as a metabolic alkalosis, all together in one case. And this is about as difficult as it gets. So if you're able to get this one correct, great job, and you'll be set for interpreting ABGs in the future. So that's all I have for you guys today. When it comes to reading ABGs, practice makes perfect, or at least an improved intuition and efficiency. So keep up the practice and see you guys soon.